Okay, we're going to call the meeting to order. Rise for the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you.
Good evening, everyone. Catherine, would you please take the roll?
Yes. Director Wallace?
Present.
Director Nicholson?
Present.
Director Stewart?
Present.
Director Danielson?
Present.
Director Epen?
Present.
Thank you. Nancy, would you please?
Yes, it's my pleasure tonight to introduce Dr. Prasad Kilaru. This won't be the first time that he's appeared before the board to present an education session. But I want to remind you of his credentials and his history here at the hospital. He graduated from Guntur Medical College in India. He completed his general surgery residency at Bay State Medical Center, which is affiliated with Tufts University in Springfield, Massachusetts. He subsequently completed his plastic surgery residency at the University of Southern California, Los Angeles County Medical Center, and on the heels of that, he completed a fellowship in hand surgery and microsurgery, also at the University of Southern California, Los Angeles County Medical Center. He initially practiced at the City of Hope Medical Center in Southern California for 2 years before making the move to Fremont. He started his practice in Fremont in May of 2001. Since 2005, he has been the medical director for the Washington Hospital Wound Care Program. Dr. Kilaru has been involved with the Washington Hospital Outpatient Wound Care Clinic since its inception in January of 2005. He's also completed an executive MBA at the Wharton School of Business and continues to be actively involved in the new Center for Wound Healing and Hyperbaric Medicine as its medical director. With that, I'd like Dr. Kilaru to take over the meeting.
Thank you, Ms. Farber, Dr. Romano, members of the board. I'd like to thank you for giving me an opportunity to talk about nutrition and pressure ulceration. It's an interesting topic, and it's one component of many issues that we deal with when we have patients with pressure ulcers, or as they're commonly known, bed sores. Just a brief overview. About 2.5 million people in the United States suffer from pressure ulcers each year. About 60,000 of those will die from pressure ulcer-related complications each year. And the incidence of pressure ulcers and hospitalizations related to pressure ulcers has actually been going up. Over the last decade, it's up by about 80%. The costs, as you can imagine, are also going up. In 1999, costs associated with pressure ulcer care was anywhere between $5 to $8.5 billion. In 2008, that ballooned to $9 to $15 billion. And this is seen in all aspects. So the length of stay also increases. Typical Medicare length of stay is about 5 days, whereas if you look at patients that have pressure ulcers, it's anywhere from 13 to 14 days. Typical cost for a Medicare admission is around $10,000, but with a pressure ulcer admission, that goes up to anywhere from $16,000 to $20,000. Similarly, if we're treating an acute pressure ulcer in the hospital, the cost can be upwards of $43,000. And this is usually related to specialty beds that we have to use for a lot of these patients, surgery that they may need, other ancillary services that are needed. And this doesn't even take into account the costs associated with litigation that is often seen with these pressure ulcers. When we look at hospital admissions, in 2006, there were over 500,000 admissions with pressure ulcer as either the primary or the secondary diagnosis. About 45,000 of these had pressure ulcers as a primary diagnosis, and about 1 in 25 of these admissions ended in death. Whereas almost 450,000 patients had pressure ulcer as a secondary diagnosis, and 1 in 8 of these ended in death. So you can see this is a very significant comorbidity that does increase the likelihood that the patient won't leave the hospital. A pressure ulcer is basically a chronic wound. And whenever we have a chronic wound, we want to look at why is the wound not healing. Well, the most important thing we want to look at is if there's enough oxygen going to the tissue or not. And right up there is also to making sure that there's enough nutrition to the tissue. And that could be protein, vitamins, calories, fluid, and we'll talk about each of these. We also look at other aspects, whether there's an infection, if there's diabetes or kidney failure, whether that's being treated, if the patient is a smoker. All of these things can affect how a wound or how quickly a wound will heal. So how do we address these? Well, we take each of these factors and try to address them. We make sure their perfusion or their oxygenation is as good as it can be. We address their nutrition. We look at their infection status, whether they're diabetic or kidney failure, and try to address those issues. And if I can throw a plug in for the hyperbaric oxygen, I'll throw it in. It's something that we do use for chronic wounds, although usually pressure ulcers aren't a common indication for hyperbaric oxygen treatment. The management for wounds, whether it's a pressure ulcer or any kind of chronic wound, is pretty straightforward. First thing we want to do is control the causative factors, whether it's an infection, whether it's pressure, whether it's shear. And subsequently, we want to provide systemic support, nutrition, controlling infection, things like that. And finally, we want to make sure that there's a good local environment for the wound to heal. And that's where the dressing care and the local wound care comes into play. Now, even though there are many aspects that we can talk about, for this presentation, I wanted to concentrate on nutrition and how nutrition affects healing of wounds. As you can imagine, there are many components in nutrition, calories being the most important, protein, but it's also important that we look at what the fluid status is, whether the patient's getting enough vitamins and minerals and such. The opposite of the nutrition is the malnutrition, and there are different grades of malnutrition. The earliest sign of malnutrition is what we call unintended weight loss. And there's been some studies that showed that there was a strong clinical correlation that if you have, say, a 10% weight loss in your body over a 6-month period, there's increase in mortality as well as increase in the incidence of pressure ulcers, whether the patient is admitted to the hospital or not. So we do want to monitor a patient's weight to see where they are. Undernutrition is the next step up, which is basically you have deficiency in protein and calories, but it's still reversible, and is usually reversed by feeding the patient. Protein energy malnutrition is the next step in the cascade. You have more loss of energy, but you're really not losing muscle masses yet. You're wasting, but you're wasting mostly the fat reserves that the body has. Once you start losing protein and muscle mass, then you get into cachexia, which is one of the more severe forms of malnutrition. The other side of the coin is hypermetabolism. Hypermetabolism is basically conditions where the body requires more energy than in the resting state. So if a person has sepsis, if the person has infection or had recent surgery, there is stress on the body, so they require more protein, more energy than what is normally required for a resting person. So we again need to take that into account and see if a person is hypermetabolic. And a lot of the patients that are in the hospital do fall into that category. So we need to assess that and take that into account. Dehydration, if they're losing a lot of fluid or if they're not taking enough fluid, that can again cause a problem with healing. Low body mass index is where the patient is starting from, whether they're at home or whether they're coming into the hospital. In this country, high body mass index has been more of an issue, but for these elderly patients, the low body mass index can be a real problem. And finally, with the older patients, you have problems with reduced food intake. A lot of these patients are on restricted diets, whether it's sodium restriction or carbohydrate restriction because of hypertension or diabetes or kidney failure, and that doesn't make the food very palatable. So they don't want to eat, which again decreases their intake and can affect their nutritional status. And also, if they have other reasons that they're not able to eat, if they're demented, if they've had a stroke, if they've had problems with moving and caring for themselves, then again, they're not able to eat as well or as much as they should. There are a lot of tools that we have to try to find how well a person's nutritional status is. And the fact that there are so many tools tells us that there's not one good way for us to do it. The main way to assess a patient's nutritional status is to look and see clinically how they're doing, how they're responding, how their weight gain is, and things like that. We want to assess their cognitive deficits, again, going back to the dementia and Alzheimer's or stroke, whether they can eat properly or not, if they have dysphagia. Depression can also be a problem. Certain medications can interact with food, so they're not able to keep the food down. Again, gastrointestinal problems, either medication-related or otherwise, diarrhea, constipation, etc. And again, going back to the impaired ability to eat. Now, we have a couple of different scales that we use to evaluate how a patient's nutritional status is. In our hospital, we use the Brandon scale. The Brandon scale is actually a risk assessment scale that we use to evaluate the patient's risk for developing a pressure ulcer. Within that scale, there is a nutritional component that we use, and it's pretty effective. the Brandon scale needs to be assessed every time there's a change in the patient's condition. And I think this may be one area where we're falling a little bit behind. We assess them when the patient comes into the hospital. We assess them on a daily basis. We want to make sure that we do that continuously. So if the patient's going to surgery or is made NPO or is on IV fluids, then they need to be reassessed again to see where their nutrition is and then adjust. Some of the other ones are more common in the outpatient setting. So the mini nutritional assessment is something we do for older patients, and the ADA risk assessment is something that we do for patients that are in long-term nursing facilities. There are biochemical tests that we use. Unfortunately, none of these tests are as accurate as we'd like them to be. The common tests that we use are serum albumin and prealbumin. Albumin has pretty much fallen out of favor because it has a very long half-life, so you can't really test what their nutritional progress is in a short-term period. Also, both the albumin and prealbumin are affected by other conditions such as stress, infection, things like that. So in our practice and in the wound care center, we don't use this as an absolute test, but we use it as a trend to see, okay, is it going positive or is it going negative? And it gives us a reasonable idea as to which way the patient's nutritional status is going. Finally, when we look at the individual components, the energy requirements are obviously the most important one, and we need to evaluate what the total energy requirements for the patients are. And there are a couple of different ways in which we do that. We had been traditionally using the Harris-Benedict equation, which is the big equation going into height and weight and body surface area. And what they found was for the resting individual, it's reasonable, but for any individual that's in stress or had surgery, it's not a very good indicator as to what the requirements are. The test that is the most close to finding that is the indirect calorimetry. But unfortunately, not all institutions have that ability to do that, and it's pretty expensive and time-consuming, so we don't routinely do that as a test. So again, it falls back on the clinical evaluation of the patient to see how they're responding to what we're eating and such. As I mentioned, again, it's important that we take into account the hypermetabolic state and supplement accordingly, and if we need to, giving nutritional supplements to help with that. Protein is the other important component for healing. We want a patient to be in what we call a positive nitrogen balance, meaning the amount of nitrogen that the body is taking in should be more than the amount of nitrogen that the body is excreting. The basic requirement for resting adults is about 0.8 grams of protein per kilogram body weight. In older adults, it's actually higher. We need about 1 gram per kilogram. And then when you have stress of healing, pressure ulcer, surgery, etc., that requirements actually go up anywhere from 1.2 to 1.5 grams per kilogram. So we need to make sure that we're supplementing and providing enough protein in that manner. We also need to make sure that we're not missing loss of protein, whether it's from body fluids being lost, NG tube output, urine, diarrhea, etc., or if a person has kidney disease and they can't take the protein that they normally would like them to because it can affect their kidneys, we have to kind of monitor that and go slower when it comes to the response for that. Fluids is another area that we need to look at. We need to provide at least 1 milliliter per calorie of fluid. If the patient is dehydrated, that affects their ability to heal. It increases their likelihood of developing pressure ulcers because the skin is not as elastic and doesn't have the same level of resistance as normal skin does. We want to make sure that we account for fluid losses. In addition to the fluid that we're giving them, they could be losing fluid from diarrhea, chronic wounds, draining wounds, etc., and replacing those. And then finally, there are components that are important for healing: vitamin C, vitamin A, zinc, copper. We actually check levels for these vitamins as well as minerals in the blood, and if we need to, supplement them. Now, there was actually a white paper done by the National Pressure Ulcer Advisory Board that came out in 2009, and they looked at basically nutrition to see how it affected pressure ulcers and what we could do to decrease the incidence of problems associated with nutrition and pressure ulcers. And they came out with a guideline and a set of recommendations. And this is pretty much what we try to follow, not only at this hospital, but across the country as far as what we can do for these wounds. The recommendation is that we should have a nutritional assessment at admission and after each condition change. As I mentioned, we do that with the Brandon scale, where we check our patients daily. Even if there is no change, we check the Brandon scale rating every day to see if the patients are at a higher risk for nutrition or not, for nutritional problems or pressure ulcer problems. I think what happens is we get into this trap where the patient's having surgery, they're not eating for a day, then they're a little nauseous, then they go 3 days, 4 days, and before you know it, they're 4 or 5 days out from surgery, and they're quite far behind in their protein and calorie requirements because they already are under stress or hypermetabolic state because of the surgery or what have you, and then everything kind of falls back. So it's incumbent upon the team, and especially the physician, to look back and see how quickly we need to start nutrition or start nutritional supplements if they're not able to take care of themselves. Again, going back to that, what we're saying, assessing what their weight is to see if they're coming in underweight or undernourished, and see if they're able to eat properly and see if they're able to take adequate nutrition properly. For the calories, for the pressure ulcers, the recommendation is anywhere from 30 to 35 calories per kilogram. And one of the recommendations, which was kind of controversial, but which is recommended by the white paper, is that we take some of these elderly patients off their dietary restrictions so that we take away their sodium restriction or their carbohydrate restriction, try to get them to eat more just to provide more calories and address their sugars or their other problems as and when they occur. We also had done studies looking at nutritional supplements, and they found that nutritional supplements work better when they are given between meals as opposed to with meals. Because when they're given between meals, they provide that extra calorie boost, whereas when they're taken with meal, it takes away the appetite, so they really don't want to complete their meal also. So that's one of the recommendations that's made. And obviously be a lot more proactive in considering nutritional support, whether it's enteral, through the gut with the feeding tubes, or parenteral through the IV. For the protein recommendations, again, as I mentioned earlier, it's 1.2 to 1.5 grams of protein per kilogram body weight, and also to monitor the renal function and make sure there's adequate fluid, and replace the vitamins and minerals also as needed. There are a few areas where work is being done. One is looking at appetite stimulants and also anabolic steroids to try and see if that will increase intake and provide a positive nitrogen balance. Areas where there's not a lot of work done yet, but is that research is starting to look at is malnutrition in the morbidly obese patients, because even though they're morbidly obese, a significant number of them, especially the elderly, have problems with protein, especially vitamin and mineral malnutrition. And then looking at parameters for end-of-life care, as well as parameters for when a person should go on enteral feeding, whether it's tube feeding or putting a gastrostomy tube in place. And there are no clear-cut guidelines for that, but those are the areas that are still being looked at. So as you can see, for one small component in the many factors that are associated with nutrition, there are a lot of issues that come into play and a lot of areas where we can be tripped up. So I tell my patients, similar to what Ambrosia Perret said, that we'll do our best, but for the most part, God does the work and we take the credit for it. Thank you.
Hillary, are there any questions? Comments? Thank you, Dr. Okay, we're going to move on to the consideration of the minutes of the February 8th, 22nd, 27th, and March 9th meetings.
So moved. Second.
Okay, all those in favor?
Aye.
Opposed? Motion passes. Now it's time for oral communications. Any oral communications tonight?
Yes.
Okay. Thank you. Okay. Andrea Schachter. Good evening, Andrea. We try to keep the limit of the conversation to 3 minutes, if that's possible. Okay.
Hello, I'm Andrea Schachter, and I'm representing the League of Women Voters of Fremont, Newark, and Union City. This is Sunshine Week. Scheduled for March 11th to 17th, Sunshine Week is a national initiative to promote dialogue about the importance of open government and the freedom of information at all levels. Participants in Sunshine Week include news media, libraries, civic groups, and all citizens interested in the public's right to know. It seeks to empower all people to take an active role in government, and this year's theme of Sunshine Week is Put a Little Sunshine in Your Government. In honor of Sunshine Week, the League of Women Voters of Fremont, Newark, and Union City is offering training to all public entities in the Brown Act the California law that governs meetings for all public commissions, boards, and councils. The intent of the Brown Act is to ensure that the people's business, including deliberations and decisions, is conducted in public. The simple act of transparency provides ordinary citizens with access to information that can help them make decisions and build a better life. Throughout the year, the League positions observers at many local meetings to ensure compliance with the Brown Act. And we've noticed occasions when compliance appears to be lacking. That is why we believe it is important for public bodies to revisit their understanding of this critical law. Let's work together to bring sunshine to our local government and our community. To schedule a Brown Act training session, please contact the League at our website, www.lwvfnuc.org. Click on Contact Us, and then click on President. Thank you very much.
Thank you, Andrea. Thank you. Okay, we will now move to written communications. Dr. Romano.
Thank you, Mr. Wallace.
I'd like to present the following credential action items. Recommended for appointment are Fiona Henderson in pediatrics to provisional active, Dipali Lal, another pediatrician, to the provisional ambulatory staff, and Shengming J. Liu, also a pediatrician, to the provisional active staff. The reappointments for this month are Mark Avon in urology, Omid Azizarad, intensivist, Stephen DeGallen, cardiology, Rodora Dela Cruz, pediatrics, to the ambulatory staff, Shirley Leong in pediatrics, Bruce Lynn, radiology, Robert Miller in physical medicine rehabilitation, also to ambulatory, Dale Minkin, an oral surgeon, and to the courtesy staff, Nazra Naimi, anesthesia, Trang Go, OBGYN, Kashmiri Ragi, medicine, Stephen Ross, anesthesiology, to the administrative staff, David Tay, nephrology, active staff, Tim Choi, cardiology, active staff, and Youssef, medicine, to the active staff. We would like to continue the previous conditional reappointment for Dr. Martin Gass, who is on a leave of absence. We'd like to discontinue proctorship and advance staff status for Dr. Xiaoshuan Chen in medicine, moving from provisional to active staff, and also Jessica Seabury, a physician's assistant, from provisional allied health to allied health staff. We'd like to recommend discontinuing proctorship and advancing to active staff status for Teginder Denoa in family medicine. We would like to recommend advancement to provisional, from provisional to ambulatory status for Jennifer Louie. We would like to recommend extending proctorship and provisional status for Nancy Pham Thomas in OBGYN. We would like to extend the proctorship and the provisional status for Dr. Andrea French from 4/1 through 6/30, and extend the proctorship and provisional status for Dr. Fazalat from 4/1 through 9/30 of this year. We would like to recommend a transfer from provisional active status to provisional courtesy for Dr. Fazalat. We would like to recommend approval of a 6-month extension to the leave of absence for Dr. Burke. We would like to recommend approval for additional requested privileges to Dr. Mary Maish. The privileges requested are general surgery, gastrointestinal endoscopy, and advanced laparoscopy. We'd like to approve the request for withdrawal of obstetric-only privileges for Nancy Pham Thomas. She will maintain her GYN privileges as a provisional active staff member. Finally, there are several resignations. Andres Aldrete from emergency medicine and Christine Ye from pediatrics, both having new employment elsewhere. And then the following are all teleradiologists whose contract has been terminated. Lawrence Bubb, Wilson Wong, Benjamin Bach, Brian Burgoyne, Thomas Fiorito, Jason Grennan, Kathy Keller, Schwan Kim, Lawrence Sanders, James Tagle, Igor Zaitsev, Thomas Spinuzza, and Alan Miyamoto. Thank you.
Thank you, Dr. Romano. Are there any questions? Okay, may I have a motion for the approval of the credentialing action items?
So moved. Second.
Okay, all those in favor?
Aye.
Opposed? Motion passes. All right, good evening, Sharon. This
Good
is
evening.
time for the Service League report, and welcome to our meetings.
Thank you very much. My name is Sharon Stagg, and I'm the new Service League President for the year 2012 through 2013. My background is commercial construction management. I've also worked for a nonprofit in various positions. I decided to join the Hospital Service League after retiring and found that the last 4 years have been very rewarding. My favorite area to volunteer would be ER in our companionship program. It's always a joy to make someone's day a bit brighter. At our 57th annual meeting held this last mid-February, the Service League Board presented the hospital with a gift of $70,000 for the purchase of a new stress fracture table for the hospital operating room. In late February, Jeannie Yee, our new first VP, and myself attended the Cause Volunteer Conference in San Francisco. It was a phenomenal conference where all hospital directors of volunteer services and volunteers shared best practices. There were 10 states represented at the conference. In early March, we held our new Service League board orientation. The new board received a wealth of information, including background and history of the hospital as it pertains to the volunteers. We also had the opportunity for questions and answers. I am confident that we have a very strong board and one that will be committed to the Service League. As the new league's president, I'm looking forward to working and getting to know all of the staff and all of our wonderful volunteers, the hospital board of directors, and Nancy Farber. Thank you.
Thank you, Sharon. Dr. Romano, medical staff report.
I'd like to present the following medical staff report. At present, there are 20 total pre-applications. However, one has been voided for having not been returned within 90 days, and one is incomplete at present. 2 are from physician's assistants, and interestingly, 4 are from Diablo infectious disease, which, as an aside, may actually represent sort of the tip of the iceberg of physicians from St. Rose looking for privileges here. We have 10 applications in process. About half of them are from pediatrics from different areas. In total, we currently have 531 members of the entire medical staff and allied health. 397 of those are active and provisional active members. Of those 531 total, there's 197 in medicine, 94 in surgery, 53 in family practice, 60 in pediatrics, 39 OBGYN, 24 in anesthesia, and 37 in radiology. Thank you.
Thank you.
And with your permission,
Yes.
if I may read this letter. This is from the California Transplant Donor Network, which I received as Chief of Staff this month. It says, "Dear Dr. Romano, on behalf of the 1,075 local transplant recipients' lives that were impacted in 2011, I wanted to personally thank the team at Washington Hospital for your support of our mission at the California Transplant Donor Network. We finished the year with a record-breaking number of local organ transplant, 1,075. With your help, we supported 299 local organ donors and their families, as well as 1,214 local tissue donors and families. All of these metrics represented a record-breaking year for our organization." That was sent from Nicole Neidlinger, who's the medical director.
Thank
Thank you.
Thank you, Dr. Romano. Nancy,
Ready for the
yeah, calendar. yeah.
Okay. First, we're going to go with the construction update by Ed Fayan, and he has a really cute little video about the installation of the modular building in front of the ER.
Okay, so why don't we start with that, the video. And this is the This is the expansion of the emergency department. That is an interim arrangement before we get to the Phase 1 building, which includes a brand-new large emergency department and critical care area. This is to tide us over until then. And this building will house larger waiting spaces, probably 2.5 to 3 times the size of the waiting space that we have now. It'll have triage, it'll have registration, it'll have a place for ambulance and police, and it will also have a metal detector at the front entry for everybody coming in, and lockers and such as that to put items that we don't want to have brought into the hospital. So without further ado, we'll run this video showing you the modulars being put together. So those modulars became watertight that evening, and they're working on putting the insides together right now. Starting next week, we'll see work going on what they call the portico share, or the awnings out front over the top of it, stairs, rails, ramps, things like that. So we're still when they start the work on the structure of all that, we'll be 30 days out from that. Once that gets started. I'd like to then move on to our construction report of the big projects that are now wrapping up in the side and back of the hospital. So we first have a little bit to talk about with the central plant, and the big news for this past month was oxygen tanks, and these are the last items to be brought to the central plant, and there's 2 different tanks. One's a 6,000 gallon tank, and another is a 1,500. It's a main tank and a backup. And these were put in place at the beginning of the month, and we just have multiple shots of those being made complete. These are the evaporators that go with the tanks, and this is sort of your final look that you can see the evaporators out over the top of the fence. I should go back and just mention that everything in the central plant is now tied into the hospital and functioning. All the main equipment, with the exception of oxygen, which gets filled and certified in the next 2 weeks, and then medical air and vacuum as well. That all has to get certified and tied in. So by the end of this month, we should be 100%. But everything, heating, ventilation, water, steam, everything else is operational, and the hospital's tied into the central plant. This is just showing you that they're finishing up the work on the transformer rooms. Last time you saw this, it was still an open building. That's been closed up, and those are going to be made hot within the next 3 weeks, and we'll have PG&E power coming in through this station versus the transformers that are located in the back by the Whitaker building. Okay. On the Center for Joint Replacement, we basically have views of the 3rd floor. That's the main thing that's been worked on and is nearing completion. This is, as you might remember, a combination of a 10-bed unit and an office for Dr. Dearborn. So this is the view as you come off the elevators on the top floor. This is a waiting space and a greeting desk for Dr. Dearborn's office. This is the nurse's station in the 10-bed unit. A couple different looks at that. And this is the patient care corridor. This is a shot of the inside of what will be Dr. Dearborn and Saw's office. And this is the Dearborn and Saw offices on the left, and the windows and hallway to the fire exits on that side. And you can see the work in the exercise garden is continuing to go on, and they're making good progress there. Our final completion date is May 19th, and substantial completion by the middle of April, with final completion May 19th. Any questions? Yes, ma'am.
Yeah, I got a question. In one of the shots, I think it was in the emergency room, you saw the side of the building with the clouds reflected. Was that the Joint Replacement Center? It was a mirror effect that was really phenomenal. I stumped you.
You did, but let's see if we can.
It might be the Deccan Plaza building.
Was that what it was?
Yeah.
Not there, not there. That one,
No, that's the Deccan Plaza.
okay. It's just very impressive with the way that you photographed it. Thank you.
Any other questions? Thank you, Ed.
Thank you.
Okay, we'll go ahead and go over the rest of the calendar. On February 10th, we had a hand washing presentation at Grimmer Elementary School in Fremont. We had 38 children introduced to proper hand hygiene and how to prevent infections and the spread of germs. On February 11th, we did our abdominal aortic aneurysm screening, which was a program started by Morris Hyman. Dr. Ash Jain and Dr. John Thomas Mahegan participated in this screening event. There were 89 people screened. 8 abdominal aortic aneurysms were detected. That's a big deal, because it could be a fatal event for those 8 people. On February 14th, we did community education, and it was on the subject of the heart of the matter, minimally invasive heart surgery, and nutrition after heart surgery. See, nutrition has come up again. We had 22 people in attendance, and Dr. John Cecil Walks, our cardiothoracic surgeon, presented this program, along with Lori Roffelson, our registered dietitian. On February 15th, we had a program on health insurance options and making sure your kids are covered. Linda DeWall, our health insurance information service coordinator, gave this program. And this program targets families who've lost their health insurance coverage and may qualify for low-cost health insurance programs called Healthy Families. And this is something that's offered by the state of California, and it includes medical, dental, and vision coverage for children. On February 23rd, we did a program in the Women's Health Center on getting ready for pregnancy. Dr. Jing Dai, obstetrics and gynecology, made this presentation on the essentials of planning and preparation for a successful pregnancy and delivery. We had 7 people attend. On February 23rd and 24th, I did a series of brown bags for our employees about the need to preserve St. Rose as a community hospital and the proposals that the district was going to place before the County Board of Supervisors, whose help we're attempting to engage in the formation of a joint powers authority that will preserve St. Rose as a community hospital. The employees were invited to attend one of 3 informational discussions that were held on February 23rd and 24th. On February 25th, we did community outreach on college information and resource fair that was held at Cal State, East Bay, and Hayward. We provided information on Washington Hospital's programs and services. And there were 250 people that attended that program. On March 1st, We had a program on diabetes. Are you making progress setting goals to manage your diabetes? And Vida Reed, RN, our certified diabetes educator, was the presenter. We had 28 people in attendance. On March 6th, we had a program on World Kidney Day and kidney transplants, and Dr. Lucy Umena, nephrologist, was the moderator for this program celebrating World Kidney Day. We had 67 people in attendance. It was a very good program. On March 6th, we did another program in our stroke education series, and it was an introductory program on stroke and risk factors for stroke. Doug Van Houten, RN, and Dr. Ash Jain were the presenters. We had 13 people attend. On March 9th, we had a patient safety awareness education fair, and we sponsored this education fair for physicians and employees to provide education and updates on radiation safety, prevention of catheter-associated urinary tract infections, and prevention of central line-associated bloodstream infections. Over 100 employees and physicians attended. On March 12th, a contingency of Washington Hospital and myself attended the Board of Supervisors, County of Alameda Health Committee meeting in Oakland, where we were able to discuss our proposal for saving St. Rose. Yesterday at the Alameda County Board of Supervisors meeting, we were there again for a vote. The supervisors did take a vote to make $2 million available to help save St. Rose, just as this Board of Directors did back on February 22nd. They also authorized Alex Briscoe to go forward with negotiations with Washington Hospital and other interested parties in the formation of a joint powers agreement with which we would ostensibly have a management agreement, and that Washington Hospital would provide the ongoing management for St. Rose. On the 14th, today, staff, myself, and legal counsel from both parties, Washington Hospital and the county, met in the conference room at the hospital in administration to begin the discussion of how to put that JPA together. And we started about 9 o'clock, and the meeting went past 1:30. So there's lots to talk about, but we are beginning to make progress on how the county and Washington Hospital can work together to preserve St. Rose, not just as a hospital, but as a community hospital, accessible to the 355 physicians who are on staff there and their patients. The other alternatives are, quite frankly, bankruptcy and closure, acquisition by Prime Health and Prem Ready, and the other would be to be taken over by the county. St. Rose's preferred solution, the solution that their board supports, is the proposal that Washington has brought forward. I think the Alameda County Medical Association has now gone on public record as supporting that, and so have many of the labor unions. Progress is beginning to be made. There have been some long days in discussion, but we're moving in the right direction. There's a tremendous amount of concern about the financial stability of St. Rose while we are getting this work done. And we're hopeful that we'll be able to help her shepherd her way through all of this without having to file bankruptcy. Sometimes getting these very complicated transactions together do take time so that everybody feels comfortable, and time is the one thing St. Rose does not have. So it's kind of a race between getting consensus and meeting the very specific needs of St. Rose. On the 14th, today, we also had a program here at the hospital, the Washington Women's Center, and the subject was fibromyalgia We had 20 people in attendance. Dr. Barry Shibuya, who's a rheumatologist, presented the latest research, treatment, and self-help strategies concerning the fibromyalgia disease process. In terms of upcoming health promotions and community outreach, on the 17th, we're going to have the Medical Explorer Healthcare Career Day here at Washington Hospital from 9 in the morning until 3 in the afternoon. It's going to be a busy day for Chris Lavoie. The Medical Explorers are sponsoring a career day for students from the district area high schools, so there'll be multiple schools involved. The day is designed to introduce juniors and seniors to the diversity of employment opportunities in healthcare. Dr. Vandana Sharma, oncologist and medical director of our genetic counseling program and medical director of our oncology program, will deliver the keynote address on balancing family and career while working in medicine. There will be 3 breakout sessions that will introduce students to genetics, nursing, the childbirth simulation lab upstairs, the joint replacement center, the food services lab, engineering, imaging, bioethics, and IT in healthcare. So it's a pretty healthy complement of job opportunities. The day is going to end with a career fair where participants can speak directly to Washington Hospital staff and view medical equipment and technology displays. I'm looking forward to that. That's going to be a big day. On March 20th, we'll be doing more community education. The subject this time is Don't Let Back Pain Sideline You, Pain Management and Physical Rehabilitation. Dr. Robert Miller, who is a physiatrist, will be presenting this program along with Dr. Jenny Multani, who is a neurosurgeon. And they will address issues around pain management, surgery, rehabilitation, and techniques to lessen back pain and discomfort. On March 24th, we will be holding a Stroke Awareness Day, and this will start at 10 in the morning and go until 1 p.m. This will involve Dr. Ash Jain, and it will provide results for carotid screenings, blood pressure, atrial fibrillation, blood glucose, and cholesterol screenings. All will be provided. And Fremont Bank is co-sponsoring this event. We want to thank Fremont Bank for doing that with us. On March 30th, we'll have our Doctor's Day luncheon. This is something we do every year to express our appreciation to our voluntary medical staff. And this year, the luncheon will be provided by Strizzi's Restaurant. On March 31st, we will have our 6th annual Women's Conference. And this one is entitled Mind, Body, Energy. It starts at 9 in the morning and will go until 2 in the afternoon. Dr. Victoria Leapart, who's a gynecologist, will deliver the keynote address, and it's entitled Aging Gracefully. I think I better sign up. And Dr. Vandana Sharma, oncologist and medical director of the genetic counseling program and oncology program, will present a program on Can Lifestyle Changes Reduce Your Risk of Cancer? Dr. Barbara Kostick, who's a family medicine medical director and is the physician who works so hard in our tattoo removal clinic, is going to be speaking on age-appropriate screenings for women. And Makaria Meyer, registered dietitian, is going to address the connection between food and mood. We will have Karen Sindlar there, an exercise therapist who's going to lead a Tai Chi session. It sounds like it's going to be a very nice day. On April 2nd, we're going to have a community education program entitled Turning 65, Get to Know Medicare. It starts at 6:30 p.m. and will run to about 8:30 p.m. Linda DeWall, our Health Insurance Information Service Coordinator, and Christy Caracappa, our Health Insurance Information Service Coordinator, will present this program. I think this is particularly useful because they will discuss Medicare, Medi-Cal, Medicare Advantage plans, Medicare supplemental plans, and Medicare prescription drug plans. And all of this can be very confusing. So it's good to have someone give some insight into these programs and how to manage your way through them. On April 5th, we'll have another program for our diabetes population. The subject will be diabetes neuropathy, the cause, effect, and treatment. It starts at 7 p.m. And Dr. Ravinder Kalan, who's a neurologist here at Washington Hospital, is going to speak about diabetes nephropathy, kidney disease, and the damage that occurs in people with diabetes. This past month, the foundation made the announcement that this year's golf tournament will be held on Monday, June 25th at Black Hawk Country Club in Danville. Proceeds from the event will benefit cancer services and hospice care at Washington Hospital. Participants in the tournament will enjoy a round of golf at one of the most exclusive clubs in the region, followed by a reception and an awards banquet. Our golf committee chair, Lamar Hinton, says he's very excited about this new venue, and we're hoping that you'll all come join us for a great day of golf. Board members, I hope we can count on you. For reservations and sponsorship information, you can call the foundation at 791-3428. During the month of February, Washington on Wheels, our mobile health clinic, continued to serve the community at all of its usual places, the Fremont Senior Center, the Fremont Family Resource Center, and the Silliman Activity Center in Newark. They also provided healthcare services to students at Irvington High School and Grimmer Elementary School, both located in Fremont. WOW was not able to provide services for 2 weeks in February due to repairs on our van generator, so it was offline for 2 weeks. In terms of internet marketing, on February 2012 this year, the health care system's website had 29,447 visits, 21,423 unique visitors, which resulted in 91,665 page views. The Physicians Finder section this time pulled ahead of the employment section, and they had 15,322 page views. The employment section had 14,955. The volunteers page had a healthy number of views at 9,062. About Washington Hospital had 8,192 page views. The Women's Health and Pregnancy section had 3,682 page views. Our InHealth, Channel 78, in the month of February, aired a new health and wellness lecture titled Treating Infections in the Body, Learn About Sepsis. Staff also completed shoots for a new PSA focused on shingles, an Inside Washington Hospital show featuring the Washington Township Center for Sleep Disorders, and the Facility Master Plan Update, Part 2, featuring training at the Central Utility Plant. Other completed shoots included a health and wellness show entitled Minimally Invasive Heart Surgery, a Diabetes Matters lecture entitled Getting to the Heart of the Matter, and the installation of the modular emergency department units. In addition, InHealth captured a special board meeting, and an employee brown bag. The Employees Association was also busy. They completed an employee appreciation event where local businesses offered discounts for Bay Area activities and dining, and a total of 2,684 certificates were sold. If all of those certificates are utilized, it would amount to a total savings of over $500,000 in retail prices. The WHEA scholarship application, which is available to graduating seniors who are dependents of Washington Hospital employees, is now available on the intranet. We're planning a blood drive in conjunction with the American Red Cross, which is planned to take place on March 19th here in the Conrad Anderson auditoriums. And finally, the Employee of the Month for March is Gloria Bonilla. She joined Washington Hospital more than 7 years ago as a staffing clerk before transferring to her current position as a payroll clerk in 2006. Dave Tapia, Gloria's manager, says he enjoys working with her. She is conscientious, hardworking, and very reliable. She is dedicated and sensitive to the needs of our employees and goes the extra mile to help them out with their payroll questions. Her colleagues describe her as having an excellent work ethic and being highly trustworthy. So we want to offer our congratulations to Gloria.
Well, thank you, Nancy. Any questions? Okay, then I guess we'll move to the quality report.
We have a pinch hitter tonight. Stephanie is away visiting with family members on the East Coast, and Chris Lavoie, who you all know very well, is here to give the quality report.
Thank you. You took my line. That's exactly what I was going to say. All right, so I am here tonight to give review the dashboard for quarter ending December. The first indicator, one of our patient safety indicators, is handoff communication. This is the communication that occurs when healthcare providers transfer care from one to another. And as you can see, we were better than goal. The next patient safety issue is a patient safety goal and procedure timeout. And in this quarter, the result was not significantly different than our stated goal. The next is falls with moderate injury. And I remind you with this one that the data that is listed for December is actually a month back, and so it's really activity that occurred for quarter ending September. And there were no falls with injuries that quarter, and we remain better than the CalNOC average in this area. The next is the issue of severe sepsis mortality. And in this quarter, we were just percentage points above the stated goal. Pressure ulcer incidents. You heard about pressure ulcers this evening from Dr. Killaroo. And in this indicator, our results have been better than or equal to the CalNOC benchmark for the 2 years that you see reflected on the graph. Our nosocomial hospital-acquired MRSA infection rate, there was one infection during this quarter, and it was related to a central line. There is a task force that has been formed to look at central line associated infection, and that group is working on developing an action plan. The next is a surgical site infection caused by MRSA. And you can see from the graph that there have been no MRSA surgical site infections for the 2 years listed. And in total, we have gone 928 days without an MRSA surgical infection. The next is the issue of catheter-related urinary tract infection. You recently saw the flyer that Nancy showed for a staff education that just occurred on this subject. And note that there has been, on the graph, you can see that there has been a slight change in the definition, and that has changed the look of our graph a bit. There were 5 infections in this quarter. The Antimicrobial Stewardship Committee has formed a subcommittee to evaluate this issue, and they are looking at the possibility of an IHI type prevention bundle that they will be rolling out soon. Next issue is ventilator-associated pneumonia, and we continue to meet the goal. And with this indicator, we have gone 749 days without a ventilator-associated pneumonia case. Hospital-acquired C. difficile. This shows that our results are better than the goal this quarter, and all of the cases of hospital-acquired C. difficile have been determined to have been related to to the use of antibiotics. This is a new report that you're seeing for the first time tonight. This is central line associated bloodstream infection in critical care. And the Washington Hospital is being compared on this graph to the state and national data. Benchmark hospitals are chosen because they are of similar size and type to Washington, and the data is risk adjusted for size and type not only of hospital but of intensive care unit. So and you see that this is the first report, and it is for the quarter ending March 2011. And in this quarter, there were no infections, and as a result, Washington Hospital was better than both the state and the national benchmark. Turn now to a summary of our core measure results. And in each of these, the data is compared to our own data, but also to CMS, and that information comes from CMS's Hospital Compare. So the first one is acute myocardial infarction or heart attack. And Washington Hospital is better than benchmark for all of the indicators except aspirin at discharge and statin at discharge. And there is a work group that evaluates this data every month, and they are looking at those two issues. The second core measure is heart failure. And again, Washington Hospital was better than benchmark, except for one indicator, which is evaluation of left ventricular function. And there is some work being done at the hospital on this issue, looking for a system way. This is related to bringing forward the appropriate documentation on the record. And like I said, there is work being done looking for a system solution to be able to make that data easily available to the physician. The next core measure is pneumonia. And all of the results for Washington Hospital are better than benchmark, with one exception, and that is antibiotic selection. And there has been a change made in the pre-printed order sets that we are believing will impact and clarify this issue. Next core measure is Surgical Care Improvement Project, or SCIP, as we call it. And all of the results for Washington Hospital for this indicator for the quarter were better than the benchmark. And the last core measure is Hospital Outpatient Program, or HOP, as we call it. And there are two indicators in this core measure, antibiotic timing and antibiotic selection, and both of them were better than the benchmark. So with that, I will answer any questions.
Thank you.
Thank you.
Thank you, Chris. Okay, Chris Henry.
Okay, tonight we will be looking at the results of operations and the resulting financials for January 2011. And we'll start with our operating indicators. January 2012. I've got to get my year right here. Average daily census for the month was pretty darn close to budget at 195.6. We had 1,152 admissions, 8 above the budget of 1,144. Patient days were 28 below budget at 6,065. Our average length of stay based on discharges, not on admissions, was 4.98. We'd expected 5.33 in the budget. Looking at utilization, case mix index for January came in at 1.400, a little bit lower than budget. We had 152 deliveries during the month, 19 below the 171 we had anticipated. Surgical cases were 15 above budget at 379. That includes joint replacement cases that were 6 above budget at 114. Our neurosurgical cases for the month were 21. We'd expected 19. Cardiac surgical cases for the month were 7. We had budgeted for 15 in January. PTCA procedures were 34 below budget at 38. Outpatient visits for January came in 40 above the budget at 9,169, and the emergency room was exceptionally busy in January. They saw 4,544 patients in January. It's 189 above the budget of 4,355. Looking at productivity, our productive FTEs for January were actually 109 below the budget at 1,365.5. We had 240.4 non-productive FTEs for the month, giving us total FTEs that came in 68.2 below budget at 1,600, almost 1,606. Our full-time equivalents per adjusted occupied bed for the month were below budget at 6.53. We'd expected 6.64 for January. Moving into the financials, and as we always do, we'll look at the Governmental Accounting Standards Board presentation first. This is the presentation we use for our audited financials. Total patient revenue for January came in almost $5.4 million below budget at $169,767,000. Our contractuals for the month came in at 73.85, a little bit below what we expected at 74.3, giving us net operating revenue for January that came in $485,000 below the budget at $44,716,000. Operating expenses for the month were $152,000 above budget at $43,168,000. The variance largely driven by our salaries and wages were below budget with our lower FTEs, but that was offset by our health and welfare claims, which continued to be higher than we expected in the budget. So we end the month with an operating bottom line about $637,000 below the budget at $1,548,000. Non-operating income for the month from a GASB perspective came in $1.8 million above the budget at $3,098,000. That largely driven by an unrealized gain on our investments of a little over $1.4 million, giving us a total bottom line from a GASB perspective almost $1.2 million above the budget at $4,646,000. Take a quick look at our Financial Accounting Standards Board presentation, and for those not familiar with this, this is the way the financial markets like to look at us. Our operating bottom line stays unchanged at little over $1.5 million. We pull out that unrealized gain on investments and our property tax revenue that's used to service our general obligation bonds to give us non-operating income from a FASB perspective about $329,000 above the budget at $941,000, and a total bottom line about $308,000 below budget at $2,489,000. So are there any questions on January?
Nope.
Okay.
Are you ready for February?
Yes?
The month of February saw 1,116 patient admissions that resulted in 5,948 days of care. Our average daily census in February was 205. This average daily census is higher than January's, and the high and low as of the midnight census range from 222 down to 163. The budget for February anticipated 1,075 admissions and 5,721 days of care, and an average daily census of 197. So we're going to be approximately 227 patient days of care above the budget for the month. The average length of stay for adults and children in February was lower than budgeted at 5.1. The budget anticipated an average length of stay of about 5.32. Our preliminary information indicates that inpatient revenue for the month of February amounted to approximately $135,870,000 compared to a budget estimate of $128,307,000. Of this amount, 54.5% was Medicare and 10.1% was Medi-Cal, for a total of 64.6% in government program revenue. The birthing center saw 169 deliveries in February compared to a budget of 162. Surgeries. In the month of February, there were 362 surgical cases at the hospital, Our budget had called for 344. This includes cardiac surgical cases that were 5 below the budget at 9. The inpatient surgical activity was below budget by 19 cases, while the outpatient surgeries were above budget by 37. At our outpatient surgery center, they hit spot on the budget at 526 cases. In the month of February, we had 407 cases seen in our cath lab, including 53 PTCAs. Our total cath lab cases were lower than budget by 32, and the PTCAs were lower than budget by 14. Inpatient cath lab procedures were 3 more than expected in the budget, and outpatient procedures were 35 lower than expected. In terms of non-emergency outpatient visits, in February, we had 8,626, and they came in above the budget of 8,508, and higher than last year's February. The emergency room recorded a total of 4,440 patients. I have to keep in mind February's a short month, even with leap year. It had a daily average of 153. They came in 242 visits above budget on the 22nd of February. I think everybody in the House is going to remember that date. Our census in the emergency department was 270, and we admitted 45 of those patients. That's more than a whole floor of people in the tower. It's been a significant volume, and some of the sense of this is that physicians are beginning to drift south from St. Rose to admit here with concerns about how prepared St. Rose is at this point to take care of the patients. I think we're just seeing a little bit of that drift already. Washington Clinic, Warm Springs Clinic, Newark Clinic, the Nakamura Clinic, Ohlone, and Walmart Clinic saw approximately 4,436 patients in February. So our total system emergency room and clinic visits for February are 8,876 compared to a budget of 9,197. Personnel for February. Full-time equivalents for the month of February totaled 1,615.7. This was lower than budget. The FTEs per adjusted occupied bed came in at 6.23, below the budget of 6.6. Productive FTEs were below budget by 16 for the month, and the non-productive FTEs were also below budget by 32.7. In summary, we had 41 more admissions and 227 more patient days than anticipated in the budget. Surgical cases were above budget by 5.2%, and cath lab procedures came in below budget by 7.3%. Outpatient visits for February were 1.4% above budget, while ER visits were 5.7% higher than anticipated. Clinic visits for the month came in 11.3% below budget. Total paid FTEs are below budget for the month. FTEs per adjusted occupied bed are also below the budget. Inpatient charges for the month were higher than budget by approximately 5.9%. Outpatient charges came in very close to budget. So our total hospital charges for February are going to come in above budget by approximately $7,563,000, or a 4.6% variance. On February 29th, there were 154 days cash on hand. The total days revenue and accounts receivable at February 29th was 66.24. If you exclude Medi-Cal, the days in accounts receivable are at 54.18. And I remind the board that the state of California has slowed down the payments of Medi-Cal for all the hospitals. And they tend to pay slowly to begin with, but now they've added a 3-week period to that. For us, it's not nice. For a hospital like St. Rose, it's a catastrophe. And one of the things that we have done is to attempt to get the state to give special dispensation to St. Rose so that they can release their Medi-Cal monies on time. Their Medi-Cal caseload is 40% of their volume. For them not to get paid on a timely basis is a disaster. And for a hospital that is as financially fragile as St. Rose is, I think the state is going to have to step up. We certainly hope they will. Let's see, we left off on, where did we leave off? Days cash on hand, accounts receivable, excluding Medi-Cal, was 54.18. And during the month of February, $1,168,952 of charges were approved or are pending charity assistance.
Thank you, Nancy. Any questions? Okay, then, we are going to move to our action items. Dr. Nicholson?
Yes, item A. Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to purchase a video router and 2 flat-panel video screens in an amount not to exceed $76,866. This purchase was not included in the fiscal year 2012 fixed asset budget.
Thank you. Do we have a second?
Second.
Any comments or questions?
This is a physician request. What this does is give the physician the ability to move images to various locations around the surgical field, and we currently provide this in rooms 3 and 8, and it's also going to be available in rooms 1 and 2. And physicians want it throughout. And it makes sense to make it standard.
Mm-hmm. Okay. All those in favor?
Aye.
Opposed? Motion passes. Dr. Nicholson?
Item B, Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with executing the contracts to procure the steel required to manufacture 72 base isolators for the Emergency Department Critical Care Building project for an amount not to exceed $587,470. This down payment was not included in the fiscal year 2012 capital budget.
Second. I have a second? Okay. Any comments, Nancy?
I'd like to explain this item. We're not slated to start construction until the first quarter of 2013, but we were notified by the people that construct these base isolators that the Apple campus, which has been approved for construction across the bay, is going to make earthquake protection systems like this the standard for all of their construction. And they recommended that we submit our order for fabrication for the 72 base isolators we need so that the manufacturing of our emergency department critical care building base isolators would not be delayed to wait for the Apple building. There's a 9-month lead time to fabricate the steel required for the base isolators, and we are asking the board to approve a 20% down payment for the 72 base isolators. The Apple order is so big that it would delay us more than a year, and we would like to proceed with our construction on a timely basis. So we're asking for the down payment to get going, and we'll come back for more approvals. And I'm very grateful that they notified us of this. We don't want to be waiting in line behind them.
Thank you. Okay, let's vote. All those in favor? Aye. Opposed? Motion passes. Any other items for discussion, action? Okay, we're going to adjourn to a closed session.
Brief closed session.
Brief closed session, so thank you. Okay, we're going to reconvene the board meeting and announce that there were no actions taken during the closed session. So, any other business? This meeting is adjourned.